Hello, this week's topic will be on congenital diaphragmatic hernia, a topic full of controversy. Let's get started. The usual disclaimers. Topics that we'll cover today: types, etiology, and epidemiology of CDH, prenatal counseling, post-delivery preoperative care, post-operative care, and long-term outcomes and follow-up. Embryology, so basic embryology here, 8 to 10 weeks of fetal life. There's abnormal formation of the pleuroperitoneal folds, resulting in a diaphragmatic defect, which is most commonly posteriorly, aka the Bochdelic. After return of the mid-depth structures, shortly after, the intestines and other splanchnic structures may herniate into the thoracic cavity through that diaphragmatic defect. This is thought to contribute to inhibited lung growth and development, causing both pulmonary hypoplasia, which is a reduced number of alveoli, bronchioles, arterial branches on both sides, although worse in the side that has the diaphragmatic defect, as well as pulmonary hypertension via decreased number of vessels, as well as smooth muscle hypertrophy in the wall of the arterioles. There's been proposed a dual hit hypothesis, which is something genetic or epigenetic causes both the pulmonary hypoplasia, pulmonary hypertension, as well as the diaphragmatic defect itself. Incidence is around 1 in 5,000 births with an equal male to female ratio. There is this thing called hidden incidence or hidden mortality, which is that about 1/3 of CDH, infants with CDH, are either born stillborn or die after delivery, but before they can be diagnosed. And there's also a 50% rate of elective termination of pregnancy for fetuses that have this diagnosis. About 80% of them are left-sided, 20% right-sided, with a small portion being bilateral. And about half will have some other associated anomaly, either chromosomal or congenital heart disease being the more common ones. They do have 100% incidence of intestinal malrotation, although like other abdominal wall defects, gastroschisis and falloseals seem to be less associated with midgut volvulus than intestinal malrotation in isolation. The diagnosis may be made prenatally. An ultrasound may show polyhydramnios, detection of the intestinal contents within the thoracic cavity as early as 12 weeks, although usually anatomic stains are a little bit later than that. It is not always detected even on the later 16 to 20 week ultrasounds, which can lead to a surprise diagnosis post-delivery. When it is detected prenatally, there's usually follow-up testing to evaluate for associated anomalies and genetic disorders, as well as a prenatal assessment of severity. Prognosis and what to tell these mothers. So mortality data, single institutions report mortalities as low as 10%. Population-based data has up to 46% one-year mortality. For lower risk and uncomplicated course, they might expect to spend 2 to 6 weeks in the NICU. For those with higher risk or complications, 6 to 11 weeks or even longer. Validated prenatal prognostic predictors, there are a lot of them. The most commonly ones that I've seen reported are the lung-head ratio, usually expressed as an ODE percent, ODE total fetal lung volume, percent predicted volume. You have to be careful with sometimes the exact wording of these radiology reports because several of them are presented as percentages to make sure that you get the right information. Liver up or down. Stomach up or down, which is a more recent one, pulmonary artery diameter. And there's a chart on the next slide here, which shows different categories. And this is a chart I made, so it's not necessarily that they thought that these are mild or moderate. This is just where I've placed them for the purposes of consolidating all information into one spot. And so you can see these different characteristics, most often the ODE lung-head ratio, greater than 45%, with relatively good survival, and then lesser numbers, especially the less than 50% extreme with poor survival. A lot of these have been validated almost exclusively for left-sided CDHs, although ODE total fetal lung volume does include some right-sided diaphragm hernias in their cohort. Overall, right-sided hernias do have worse prognosis than left. Additional maternal counseling. So After mentioned that they will be getting that ultrasound with the initial diagnosis, that will usually be followed by an MRI around 26 weeks and some additional testing for associated anomalies and genetic abnormalities. Once you have that information, there is some evidence that there is increased survival to discharge for infants with severe left-sided CDH. So those with ODE lung-head ratio less than 25% may be considered for referral to a fetal center. And what feto is that a balloon is placed fetoscopically into the trachea and then inflated between 27 and the later parts of 29 weeks of gestation, and then it's reversed during week 34 prior to delivery. Some increased risk there of premature rupture of membranes and premature delivery, but they did, again, for those severe CDH, did show some increased survival. Otherwise, delivery should be performed in a center with CDH expertise and ECMO availability. There's an additional chart here from NET regarding long-term morbidities for which the parents should be counseled on. And then timing of delivery. So it'd be great if NICU and surgery could anticipate it, and then delivery at term is preferred over preterm delivery, who that population has greater mortality. There is no recommendation for method of delivery between vaginal or C-section. The majority of these infants with CDH will have respiratory distress at birth, although there is a not insignificant number who will be have few or no symptoms, and those will be diagnosed later in life, some months to years later. There is also some portion that will be diagnosed immediately, but not necessarily need intubation, and may be supported with spontaneous respirations. But the majority of these will be intubated relatively quickly, and we'll go over some of the other initial management strategies from head to toe. They do need adequate analgesia and sedation. Stimulation and pain worsens pulmonary hypertension. I personally prefer dexmedetomidine to the benzodiazepines, although both have been used. Most guidelines, either institutional or international or national guidelines, recommend avoiding routine neuromuscular blockade. There is some low-quality evidence that it reduces lung compliance, at least when used during the initial resuscitation, and that it may, in babies with hypertension, pulmonary hypertension, increase mortality, at least in the era before inhaled nitric oxide. Nevertheless, it is used fairly frequently, and it was actually updated in the Canadian CDH Collaborative guidelines that use may be considered for infants who have escalating severity of pulmonary hypertension if ventilation is difficult to achieve. Neuromuscular blockade also has the disadvantage of increasing edema, which can make surgery bloodier and increase risk of recurrence. A baseline head ultrasound should be obtained as well, especially if the baby has a severe CDH and ECMO is a consideration. As stated here, infants with good respiratory effort may be monitored closely or assisted with non-invasive means, although many institutions, including Children's Hospital of Wisconsin, support routine intubation, which is also fine. Significant respiratory distress should prompt intubation, minimizing the use of bag valve masking. Usually the stomach is in the chest as well, and significant gastric distension will further compress the thoracic structures. If intubated, pressure-controlled approaches are generally recommended, with initial FiO2 at 1 to minimize the pulmonary vasoconstrictive effects of hypoxia, with weaning to follow. And then to consider the use of inhaled nitric oxide if evidence of pulmonary hypertension, although this has not been shown to have survival benefit. It is still pretty broadly used. There is a philosophy of permissive hypercapnia to avoid further lung injury, which is extremely important as these infants do not have as much lung due to the pulmonary hypoplasia. Generally tolerate CO2s, PaCO2s of 45 to 70 or so millimeters of mercury. And here's some strategies to get to those levels. The first ABG should not be drawn immediately, but given allowed 30 minutes to achieve relative stability, after which a chest X-ray will be maintained to confirm the diagnosis of CDH and OG and ET tube placement. Reliable arterial and venous access should be obtained, which is usually performed through the umbilical vessels. And then there's some different opinions on when to obtain the echocardiogram. The ELSA 2021 recommendations were to perform that echo within 4 to 12 hours of life to assess cardiac anatomy and degree of pulmonary hypertension. whereas other groups recommend deferring that to 24 hours, especially in stabler infants. As early in life, even in normal infants, there will be some degree of pulmonary hypertension, and the echocardiogram being performed later is more useful. Preductal and postductal saturation monitors should be placed. Preductal is on the right upper extremity, and postductal usually on one of the two lower extremities. It can be dependent on the baby what that left upper extremity will be doing, whether it's preductal or mixed or postductal. A lot of folks consider it to be postductal. There is NICU literature that it is not reliably so, and so it would not tend to include on that. I'm sorry, to rely on that. Appropriate mean arterial blood pressure for gestational age should be supported initially with some small crystalloid or blood boluses. Generally, these are trying to limit the amount of fluids that are given to avoid pulmonary edema. Dopamine or epinephrine may be used for additional support, with Miller known as if there is pulmonary hypertension present. We already discussed placing an orogastric tube to decrease any space occupation the stomach is doing and to limit further distension and further compression. Early on, we were targeting preductal saturations of greater than 85%, permissive hypercapnia as stated previously, with adequate perfusion and oxygen delivery prior to repair, as demonstrated by adequate urine output and normal lactate. A study looking at validated postnatal survival predictors found birth weight, 5-minute APGARs, including the absence of that APGAR, to be significant predictors of mortality, as well as signs of defect at the time of operation, and the SNAP-2 scores being the overall best predictors. In terms of timing and when to perform the repair, that is somewhat controversial as well. The optimal timing is not exactly known. There is a general consensus that repair should be delayed until there is stabilization of the cardiopulmonary state, with targets such as resolution of hypoxia, preferably unconventional mechanical ventilation, minimal or no or at least decreasing vasopressor or inotropic support, and some evidence that the pulmonary hypertension has been stabilized, such as a minimal pre-postductal gradient or off INO, or an echocardiogram showing signs that there is subsystemic or RV pressures. This is some opinions from the APSA NOT textbook, NET, with authors from IU, Boston, Yale, Nemours, and UT Houston, and they again go over some of those same parameters: resolution of hypoxia, blood pressure normalization, adequate perfusion. Here is data gleaned from other institutions. Children's Hospital Orange County to schedule for repair when it exhibits evidence of physiologic stability. CHOP with similar criteria. Interestingly, on the 2024 Canadian CDH Collaborative, they added a new 9.3 recommendation in patients who have achieved physiological stability. There is no benefit to delaying operative repair, and that's to kind of counter this idea or notion that there was a need to delay necessarily to 48 or 72 hours or some other arbitrary time point, which has been practiced in some centers, and we'll see additional data on that in the coming slides. This is the Euro Consortium recommendations. Again, that it should be performed electively when certain criteria are met, showing adequate oxygenation, ventilation, perfusion. They also commented on timing of repair in patients on ECMO, saying that the repairs can be performed during the ECMO course rather than after the ECMO course, which we'll talk about as the second controversial area. This is from the guidelines from Utah, who had studies using oxygenation index preoperatively of 9 as predicting ability to undergo the surgery successfully. So delay, in that study, which is on the next slide, delay of repair past 24 hours of stabilization is associated with increased ventilator days and later discharge dates. So if you have the baby who's stable earlier, waiting until that 48 to 72 hours mark or some other arbitrary time cutoff, not only does it not benefit them in any way, but it may harm them in the sense that there's increased ventilator days and later discharge. And this is data from the 2022 JPS study that they used to make those guidelines. And you can see that they repaired about a third of their infants within the first 48 hours of birth with good results, great survival. So this is kind of a summary of the previous slides, general consensus for when to repair when babies who do not need the ECMO. Generally, there is at least a 24-hour period of stabilization after which elective repair is performed on or after they elect to. When they are showing that cardiopulmonary stabilization, resolution of hypoxia generally reported as F5 less than 0.5, although if you're on slightly more than that, or at least stable or coming down, people have been performing surgery on higher levels, even on the oscillator, as long as it seems like it's stable or decreasing support. Normotensive on either no or minimal or downtrending vasopressor inotropic cardiac support. And then some evidence that this pulmonary hypertension has been stabilized, some combination of being off INO, having a low pre-post-ectal gradient, or echocardiogram findings such as subsystemic RV estimated pressures, or left to right bidirectional or closed PDA. And so the VICI trial, which was a 2016 study comparing high-frequency ventilation to conventional mechanical ventilation in babies with CDH, which did not find any advantage to the high-frequency ventilation, did have this other subsection with indications for ECMO, which is that any of these criteria 1 through 7 have been met at 2 different time points 3 hours apart. They did remark that all of these are subject to numerous patient-specific factors, and individual babies may meet these criteria for a variable amount of time, followed by stability, which can make the decision to initiate ECMO difficult, which is what you find in real life as well, that these infants will seem to be getting better for a time, and then meet some of these, and it's hard to exactly tell, can be hard to exactly tell their trajectory. And so often ECMO is put off because infants with CDH who go on ECMO do have some increased morbidity and mortality, not necessarily from the ECMO, but as a marker of their severity of their disease. However, you do not want to put off ECMO until you have a depleted edematous infant with bleeding lungs from the mechanical ventilation. If the infant will end up needing ECMO, you want it to be done earlier. And so there's this competing principles of avoiding it if it's not necessary, but if it is necessary, to do it earlier in the course. And so these are comments from APSA NAT, and this is in line with some of the CDH guidelines from Canada as well, that the use of ECLS to support patients with CDH is not universally available, nor is it universally accepted, with not strong data showing survival benefit. The strongest conclusion to draw from this is that continuation beyond 4 to 5 weeks is unlikely to be beneficial, and so an indefinite or a course of ECMO beyond that is not recommended, as it is likely to be futile. The APSA NAT chapter didn't include these specific indications for the initiation of ECLS, which are similar, although slightly different from other guidelines. Again, refractory prenatal hypoxia or hypercarbia or hypotension resistant to medical efforts, and contraindications, which people have been pushing the frontiers on these. Generally, significant congenital anomalies, including major cardiac abnormalities, grade 3 or 4 intracranial hemorrhage, and then weight less than 1.8 to 2, 1.8 to 2 kilos, and 30 to 32 weeks of gestation. And then just going through some other institution guidelines, because it's interesting to see how they differ. Here's from CHOP with similar folks, so they went down to 1.7 kilos. And here is one as well from the Children's Hospital Orange County with similar recommendations. These are from ELSO 2021, again, recommendations for hypoxic or hypercapnic respiratory failure. It's interesting how the different mean airway pressures vary between 14 to 17 while on the oscillator for recommendations for ECMO. In this case, ELSO recommending greater than 14. And then again, recommendations for metabolic acidosis, signs of inadequate oxygen delivery, lactate, etc. Between VV and VECMO, there is no strong evidence that one approach is better, although the majority of infants with CDH requiring ECMO are placed on VA initially. There is similar survival rates between the two groups, with a relatively low but not insignificant rate of conversion from VV to VA between 3 and 18%. There is a somewhat increased risk, almost double, of neurological complications like increased rate of seizures and stroke for VA ECMO, as might be expected from the carotid cannulation. And so the general recommendation is that this is decided by the surgeon in combination with how much vasoactive nanotropic support they're on, which can be calculated with a vasoactive infusion score. And so this is just a summary of all the different guidelines that are out there. In my personal opinion, should not be taken necessarily as gospel, but to consider ECMO if any of the following criteria are showing neutral or negative trajectory, keeping in mind that it's not just necessarily these values at one time point. Refractory hypoxia or hypotension with maximal medical management, or evidence of inadequate oxygen delivery, tissue perfusion, and then again including some recommendations that if you are using high mean airway pressures, high driving pressures to achieve those goals, that is another indication to consider ECMO. Severe air leak, or if they're not meeting criteria for operative repair at 1 to 2 weeks of life. I would give increased consideration for ECMO for individual infants with poor prenatal or early prognostic predictors. Again, to the point that if the infant will need ECMO, it's better to do it early than in an infant whose edematous from neuromuscular blockade with blood in the ET tube from barotrauma, volutrauma. Relative contraindications to ECMO, significant congenital or chromosomal, especially cardiac anomalies, grade 3 or 4 intraventricular hemorrhage, and then small weight or gestational age. And again, leaving the choice of V versus VA to surgeon discretion, and keeping that recommendation that parents should be aware that survival of infants with CDH and ECMO beyond 5 weeks is non-existent, and palliative cannulation discussions will need to occur as that time nears. So the infants on ECMO, now when should you do the repair? The timing of the repair on ECMO is again controversial, with both early repair within the first 40 to 72 hours, mid-ECMO, near the end of ECMO, and after decannulation, all of those being performed. There seemed to be general movement towards the early repair on ECMO, with the advantages that there is less bleeding, less damaged tissues, and possibly increased survival, which we'll talk about. And then how to repair on ECMO and to manage the anticoagulation that needs to be performed on ECMO to prevent circuit clotting. There is guidelines for those, most strongly for reduced anticoagulation goals and the use of aminocaproic acid. So, data for early repair, starting from Dasher 2010, 34 patients with CDH placed on ECMO preoperatively. All of those were VA ECMO, and then repaired within 72 hours. Compared to other infants on the CDH registry who were repaired later, there was improved survival and lower surgical bleeding. And this data was carried on for, again, shown in other studies, including Fallon's JPS paper in 2013, Smither's paper in 2023, as well as Dow in the Annals of Surgery in 2021. This paper was a cohort study with authors from around the world participating in the International CDH Study Group Registry. And they had two aims: repair on versus repair after decannulation, and they showed increased survival with repair on ECMO. In contrast to the previous paper from Partridge and the groups at CHOP, this paper did include non-repair in this study, where it was excluded previously, which may account for this difference. Aim 2, early versus late repair, overall mortality 63%, with improved survival in the early repair, although this went away after excluding non-repairs, and their conclusion was that the ultimate survival advantage belongs to the surgical approach that minimizes the rate of non-repair. In both repairs, this approach is early repair after ECMO cannulation. And the early repair has other advantages besides survival: reduced edema, less bleeding, and greater rates of abdominal closure. So there is evidence for early repair of infants with CDH who are cannulated for ECMO, ideally within 48 hours. There is less bleeding, less edema, and improved outcomes. For reduced anticoagulation goals and the use of immunocaproic acid, additional strategies used to limit the amount of bleeding is to consider minimal dissection of the posterior diaphragmatic lip, liberal use of electric cautery or even argon, pledgeted sutures, leaving in chest and abdominal drains. If there is bleeding on ECMO, it will eventually stop, and that is not a reason to stop ECMO if a baby otherwise needs it for cardiopulmonary. They can generally be carried on with transfusions and intermittent pauses of anticoagulation as needed, and reexplorations. In the operation itself, there's a new grading scheme for defect size, A, B, C, and D, which correlate, one of the best correlates to survival. Unfortunately, you don't have it until during the operation itself. Postoperatively, analgesia and sedation appropriate to the extent of operation. If it was performed thoracoscopically, obviously the babies won't need as much as they would during an open surgery. Gradual weaning from the ventilator, keeping in mind that if you get postoperative chest x-rays, they are likely to show pneumothorax ex vacuo. There is variability on which surgeons will leave a chest tube or not. You don't want to have it on suction and just with the understanding that the lung is small and will not expand to fill that space. If it is left to evacuate air or fluid, that's fine. It may be a risk factor for mesh infection if mesh was used. If there is significant hypotension that develops postoperatively, it's important to assess for tension pneumothorax, especially if a chest tube was not left, or from abdominal compartment syndrome after reducing all the contents of the thoracic cavity, intestines, stomach, liver, etc. back into the abdomen. Judicious fluid use, often restricting the total fluid goals to 110 to 130 cc's per kilo per day. And to consider diuretics, of course, after the resolution of the postoperative inflammatory leak. When there's signs of return to bowel function, GI enteral feeds can be performed. Initiated. Recall from the nutrition week that infants with CDH have almost a 25% greater calorie need than their counterparts, and the first year of life can be a struggle with weight gain. And again, if there is signs of decreased renal perfusion, usually this will resolve as the abdomen accommodates it, but the urine output should be closely monitored. Usually the surgery results in minimal blood loss. Antibiotics will be case and institution and surgeon dependent depending on mesh or chest tube placement. So this is what I mentioned earlier between infants with ECMO needs having generally worse outcomes than those who do not need ECLS, and that's again not necessarily a complication of the ECMO itself. Often it's the severity of the CDH disease. But you can see pretty significant rates in both groups of ventilator dependence, some mild neurological impairments, including hearing loss, and fairly high rates of reflux as well in both groups. This is a table from the AAP, I believe 2008, regarding follow-up for these infants for both surgical follow-up for recurrence, wound healing, and overall follow-up for these other complications, neurological complications, learning difficulties, hearing, weight gain, etc. These infants really need to be closely monitored, and the problems don't just resolve after the defect is closed. Some recommended reading. Then we'll move on to our questions. Mother presents for prenatal counseling. 20-week ultrasound suggested left-sided CDH with an O/E lung-head ratio of 35%. Counseling should include all the following except A, MRI around 26 weeks, delivery around term if possible, delivery at an ECMO-capable center, and then referral for feto. So we're not quite severe enough to refer feto. A full-term infant with left-sided CVH is born with a prenatal ODE ratio, lung-head ratio of 50%. 24 hours of life, she's on minimal ventilator support on FiO2 of 21% room air, and no pre-post ductal gradient. An echocardiogram shows a normal heart. The PDA is closed. When should she be taken for repair? As soon as possible, as soon as can be scheduled. If she continues to show stability, waiting another 48 hours until she's 72 hours of life to make sure she's absolutely stable before going. We should wean her to extubate first and then do it. And then someone disagreeing how stable she is and saying that she should be cannulated for ECMO. And again, the data from Utah, which is agreed on by the other guidelines, including the updated 2024 Canadian CDH Collaborative, is that delay past point of physiological stability only increases their ventilator days and increases their hospital days without benefit. Question 3. An infant is born around 35 weeks in respiratory distress. They did not have any prenatal care. They do seem to have a CDH and need rapidly escalating support. The mother wants everything done. ECMO and CDH repair should continue to be delayed as we're not yet maximally medically optimized. We should perform it immediately and then CDH repair soon after. We should not give it at all, given likely poor prognosis. Actually, there may be some people that would argue that, given the PaCO2, especially if it's above 85 or 90. But for this one, I'm saying we need a little bit more information to decide. An echocardiogram may be useful for further resuscitation and to say whether or not you have major cardiac anomalies, as well as a head ultrasound to rule out any grade 3 or 4 hemorrhage prior to cannulation.